Welcome to this ENIGMA-U session on culturally responsive care in neuropsychology. My name is Tricia Merkley. I'm a clinical neuropsychologist, and I recognize that this topic, to do it justice, would require a much longer um, lecture than we have time for today. But hopefully this will give you some appreciation of some of the issues that are at play here. So first of all, we want to consider, if we want to provide culturally responsive care, what constitute a culture? What is it that we're talking about here, and why is it important? We know that throughout the world there are changing demographics, and we can also view this as an ethical obligation to provide care that is culturally responsive, that we recognize that different people are expected to perform differently on some of our measures and may even respond differently to certain treatment interventions. And so we'll talk a little bit about some of those ethical obligations. We want to consider, why might different groups perform differently on neuropsychological tests? And we want to balance the issues of providing good quality care to people and also being sure that we are competent to provide those services. So we'll talk a little bit about cultural competence versus non-discrimination and how we can reconcile some of those apparently contradictory issues. So what constitutes a culture? There are varying definitions. If we consider a very narrow definition, that would emphasize ethnicity and race only. But a broader definition will emphasize any and all potentially salient ethnographic, demographic, status, or affiliation identities. And you can see here this long list of different aspects of things that could be related to a culture. So we have socioeconomic status, sex and gender, geography and region of a person. That could be the geographical region where they were born and or raised and or where they are currently living. So it can get rather complicated there. We can also consider the person's age, their sexual orientation, their religion, or other aspects of spirituality, disability versus ability, status, political affiliation, and so forth. This is not a comprehensive list. We would also want to consider, for example, language and things like that. We can also recognize that there are subcultures that are present. These are groups that have a shared lifestyle with their own unique norms, expectations, values, and so forth. You might think of a prison culture, for example, or looking at generational cohorts, millennials, Generation Z, and things like that. Sometimes it may be more or less helpful to think along those lines. So why is this important? The American Academy of Clinical Neuropsychology has a Relevance 2050 initiative, and I recognize that the fact that this is the American Academy of Clinical Neuropsychology is focusing on just North America. And so if we're seeing this in America, we should also recognize that it can be even more challenging to apply in other parts of the world. But this initiative states that by the year 2050, a full 60% of the American population will be considered untestable with our current toolkit of largely monolingual, monocultural neuropsychological assessment strategies. Now, a lot of these tests and measures that we use here in the United States were created and normed in the United States or in European countries or Australia, places that are largely English speaking. And so if we are seeing up to 60%, possibly more, of our own population that will be considered untestable with the measures that we have, we should consider what does the picture look like in other countries and regions where there may or may not be measures that were specifically developed and normed within those regions. The initiative also states that our Relevance 2050 title is an acknowledgement that this is not a narrow diversity issue as much as it is a broad and critical practice issue or healthcare market share issue for every Academy member involved in patient care, training, research, and administration. And so there has been more of a push recently to recognize the extent of this problem and also to develop solutions for it. We also know that in the APA Ethics Code, there are several principles in the preamble and some of the standards that emphasize these issues related to culture. Several of the principles in the preamble, for example, emphasizing beneficence and non-maleficence. Again, we want to do good. We do not want to do harm to our patients. The principle of justice and that of respecting people's rights and dignity. These are all things that should guide our clinical practice in an ethical way. And then there are several of the standards related to issues of culture. We need to operate within our boundaries of competence and also strive to broaden our boundaries of competence, especially related to cultural competence. We should avoid unfair discrimination and also use ethical methods as we select and interpret assessment measures and their results. So there are several clinical questions that are relevant here. We know that culture can greatly influence the way that clients respond to some of the following questions. For example, what do you call your problem or your illness or distress? That may vary based on their cultural background. What do you think the natural cause of your problem is? Do you think this is a medical problem? Is it a psychological problem? Is it a spiritual problem or other kind of problem? How do you think this problem should be treated? If you're going to be recommending certain treatment interventions to the patient, it would be good to get an idea of how they think it should be treated and also get a sense of how receptive might they be to your own ideas about what would help. How do you want me to help you? And who should be involved in decision-making about this problem? In certain countries, the individual will play a greater role in decision-making. In some cultures, it's more of a family or a community matter. And so it is good to know who will be involved in making those decisions. We'll also want to mention this idea of cultural competence. You might also hear it referred to as cultural humility or cultural responsiveness, and there can be some variability between those definitions specifically. But we do want to recognize that cultural competence is an ethical obligation. Sue and Sue stated that the counselor's acquisition of awareness, knowledge, and skills needed to function effectively in a pluralistic democratic society and on an organizational/societal level, advocating effectively develop new theories, practices, policies, and organizational structures that are more responsive to all groups. So this is what we are striving for. We recognize that no individual person has perfect knowledge and awareness of all different cultures that are present in the world today, but we should emphasize the need to seek out increasing knowledge so that we can better help more of our patients. Actually, we should strive to better help all of our patients. And so cultural competence does derive from this knowledge of diverse cultures, and the psychologist or the neuropsychologist really should take on the responsibility to know about the patient's culture. especially if they are not familiar with the given culture of their patient. And these should be continually ongoing efforts to develop this level of cultural competence. And as the neuropsychologist is striving to develop a greater knowledge of the different cultures, they should recognize that there can be historical lifestyles and also potentially current lifestyles. If the person lived in another country originally but has immigrated to a different country, they may have changed some aspects of their lifestyle. And so getting that good history of their culture over time can also be very important. It's also important to acknowledge cultural differences with patients, especially if there are some that could interfere with the assessment, the interpretation, and the recommendations that derive from that assessment. At the same time, it's very important that we don't assume that every individual is typical of his or her cultural group, or that their culture necessarily plays a role in their problems. So we need to be cautious. We should be developing our knowledge and understanding of the patient's culture more broadly, but always keep in mind that the patient in front of us may not be typical of that cultural group. And this can also depend on the person's level of acculturation, especially, for example, if that person is originally from a different country or culture and has since moved, and you are seeing them in a different country from where they were born and raised. We want to consider, why might different groups perform differently on psychological measures or neuropsychological measures. And there is evidence that different individuals from different groups do tend to perform in a different way overall. And there are several reasons why this might be the case. There may be biological reasons for this. There may be certain medical conditions that are more likely to be present in one cultural group versus another. People living in certain regions may have increased exposure to pollution and other toxins, and they might have different levels of access to nutritional resources. There can also be psychological impacts as well. People might perform differently on psychological measures due to race-related stress or other stressors. They can differ based on their level of risk and resilience for psychological disorders that can vary across cultural groups. There also may be disparities in diagnosis and treatment that we want to be aware of. And there can also be social factors as well, considering economic stability, considering the patient's neighborhood and their physical environment, the safety that they may or may not experience in their daily life. And there can also be educational factors as well, which we'll talk about next. So when we are doing neuropsychological testing with a patient, we always need to consider how familiar is this patient with the test stimuli that we are using. Is it possible that the stimuli might mean something different to the patient? For example, if they have never seen a certain animal before and you are asking them to name it, how fair of a measure is that? And so we do want to consider how familiar are they with the testing procedures, the materials, any technology that is used during the assessment, and so forth. We also want to consider, for the measures that we are using, what was the cultural background of the standardization sample? And are the normative data appropriate for use with this individual patient? Some measures were created and normed in one region and then may be interpreted into a different language and adapted for use with people in a different region of the world. If that was done, we want to consider if that was done appropriately and if we can rely on the results from that interpreted and adapted measure, if the construct validity is there. There's been a lot of discussion, especially in recent years, about the use of race or ethnicity specific norms. And we recognize that there are pros and cons of using race and ethnicity specific norms. And this involves several challenges, and people are in the process of trying to understand how best to address the problems that are inherent in the use of these norms, or trying to identify the best ways to evaluate people of different groups. But there are some pros of using race and ethnicity specific norms. For example, there can be increased specificity of the measures, which can lend itself to improved diagnostic accuracy. We would not want to tell a patient that they have dementia if it's just an issue of not having the appropriate norms for their cultural background. And so, more often than not, the use of these race and ethnicity specific norms could be helpful, but we always need to consider what is the purpose of the evaluation, and we need to interpret them using clinical judgment. Having said that, there are some cons of using these race and ethnicity specific norms. The norms really don't tell us why one group may be performing differently from another group. It also doesn't address the problems with construct validity that I mentioned earlier. And in some cases, you may be in the position of underestimating true impairment. And so we always want to consider, what is the referral question? Is it more important to identify all impairment that is present, or is it more important for you to be sure that impairment is present before documenting that in your report? There are several cultural considerations that we should keep in mind when doing neuropsych testing. We need to be aware that the results of this testing across cultures really may not capture the same relationships with the brain. So as we're doing neuropsych testing, we are evaluating these brain behavior relationships. We don't know how that may vary across cultures. And so that does have implications for ecological validity. We also know that there are imperfect correlations between brain pathology and performance on neuropsychological tests, even when those tests were developed and normed within the United States, for example. And so if you're using these measures that were normed and created for a certain population, and if you're testing someone that comes from that same population, even so, there's some error inherent in that process. And so as a result, there's likely to be some source of error across other cultures as well, and probably an increased level of error, unless you correct for that. We also want to keep in mind that low test score performance may not necessarily indicate neuropsychological deficits. They may not indicate the presence of disease or brain pathology. We always want to consider the person's demographics, their cultural background, other things that may impact their performance on test results that may not have anything to do with brain pathology. And it is possible for there to be overpathologizing and misdiagnosis if we don't appropriately account for social determinants of health. So, we want to provide services to all of our patients. We want to provide good quality care for our patients, neuropsychologically responsive care. But how can we provide these services broadly and in a non-discriminative way when our available research data, training, and personal cultural experience may not enable us to offer these culturally competent services. There are some questions we can ask ourselves as we are trying to decide the best course of action. For example, if it were not for the language or cultural issue, would I feel comfortable taking the case? Am I familiar with the referral question, the types of information that the referring provider is looking for? Am I familiar with their medical history and so forth? We can also ask ourselves, could this patient be better served elsewhere? Do I have a colleague who has experience with this patient population? Or, could I do this assessment with consultation? Do I know someone who could provide consultation or collaboration related to this patient's language and cultural background? And so as we consider these questions, the answers really will be informed by the client's or the patient's specific language, culture, levels of acculturation, and bilingualism. These are factors we want to consider carefully. We also need to consider what are the specific clinical issues that need to be addressed. And as a clinician, what are my clinical and cultural competencies for these clinical issues? We also want to consider potential resources in the community, or how likely and able is the patient to travel to another site where those resources may be more readily available. And so as we're trying to decide how to deal with this trade-off between the need for cultural competence versus non-discrimination, we need to carefully consider what our own competencies are. Of course, we should always strive to develop these further, but we should assess ourselves as to where is our level of competency with this individual patient. Is it something that I can bolster my competency with the use of consultation from another provider? Or, is this person really going to be better served by a colleague who's more familiar with their cultural background? We also need to know, what is available in our community, either for referral or to find someone to consult with or collaborate with on this assessment case. And then we also need to do this risk-benefit analysis, considering, is it likely that I can contribute information that would significantly improve the situation, either by myself or with consultation? We need to consider what would be the consequences of a mistake. What would be the consequences of refusing the evaluation entirely? Is there somebody else in the community or elsewhere that this patient could travel to find the answers that they're looking for? We talked about the ethics involved with this. What are my ethical, employment, and administrative obligations in this particular case? And am I able to answer some of the referral questions and not others? So hopefully, this will give you a bit of an overview of some of the issues that we need to consider as we strive to provide neuropsychologically responsive care. Thank you for your attention.